So the objectives for this session is going to review some of the pertinent differentials within fluoroscopy and radiography, highlight some of the ant minis, and of course along the way discuss some of the key clinical discussion points. Some general tips whenever I'm looking at fluoroscopy exams. You can come and talk about a lot of different long differentials, but use the keys on your images. If there's radiation, if there's surgical clips or radiation ports, they can really help you narrow your differential to one or two things. Always keep in the back of your mind the best and worst case scenarios. It could be cancer, it could be perforation, it could be ischemia. And lastly, if you're uncertain, endoscopy is always a safe suggestion. So here are some of the common topics. We're going to start up high in the esophagus and work our way down as we would normally with a upper GI and small bowel follow through, and end with the large bowel. So starting up high with the esophagus. Can't really talk much about an upper GI without talking about its Zenker's diverticulum. They're relatively common. Incidentally, you can see them at about 0.1%, up to about 0.1% of esophagograms. They're traditionally on the left side, about 90% of them. They occur at Killian's triangle. That's seen at about the C5, C6 level, right above the cricopharyngeal bar. In fact, in most of them, you'll see an impression just under it from the prominent CP bar along the posterior esophagus. These patients present with the sensation of food getting stuck or dysphagia, regurgitation, or halitosis. And it's important when you're doing the esophagram is you watch the bolus clear from the Zenker's, because sometimes they'll be asymptomatic and the bolus, the fluid, the barium, will actually get pulsed up, and you'll see aspiration towards the end of the examination. The feline esophagus, what it is multiple tiny, thin folds horizontally located. I stress the word thin. I'll describe in a second. It occurs in the lower aspect of the esophagus and makes the esophagus look corrugated. Usually it's a normal variant, but you can see it a lot of times in a reflux or scleroderma, as you see here in a 66-year-old woman with Crest syndrome. What other things do you consider when you see this? Scarring from chronic reflux or esophageal spasm, way to differentiate the two of them. Really, it's the thinness of the folds. The feline esophagus is very tiny, thin, fine folds. When you see scarring from chronic esophagitis or reflux or esophageal spasm, it's usually thick, irregular folds. One of the common impressions you see within the esophagus are the artery slings. So the first one that I could talk about is the pulmonary arterial sling. It results from the aberrant left pulmonary artery. What it does is it courses anterior to the esophagus. As you can see here on this lateral radiograph, highlighted by the arrow, the anterior impression that you'll see, it's within the mid esophagus, and runs posterior, as you can see here, to the trachea. The arrow is highlighting again where the esophagus is. These patients are usually infants or young children. They usually present with respiratory difficulty and dysphagia that's not often seen, and it's treated with surgical correction. Now, the more common of the vascular slings is the aberrant right subclavian artery. This, conversely, runs posterior to the esophagus. The anterior course is described, but is exceptionally rare. This is seen usually more towards the high esophagus, just below the thoracic inlet. You can occasionally see with the diverticulum cumeral, that's the saccular outpouching of the aberrant subclavian artery at its ostium. People describe that as dysphagia lysoria, the freak esophagus. That's a name that was applied to this from the 1790s when it was first described, because it's a freak of nature, because of the fact that it was abnormal vasculature. Airway symptoms are very rare, as usually people are presenting with dysphagia. And you can sometimes, if you're at all uncertain, you can always get a CT that will confirm the diagnosis. It's key to always think about when you're looking at images is that an upper GI or an esophagram or anything fluoro is a dynamic examination, not just acquiring one image like a CT where it's your single snapshot. You always have to make sure everything distends normally, that it opens up, that you're not just catching the tail end of a bolus. Is this really what we're seeing? And if, for example, the esophageal stricture, it doesn't distend normally. With adults, you see it with esophageal cancer, peptic stricture, long-standing NG tubes. How this occurs with the NG tube is that when the NG tube goes below the GE junction, it prevents the GE junction from fully closing, and it lets a little wicking of the peptic acid to constantly reflux. And these patients are all lying on their back. So it wicks up and causes this chronic irritation of the esophagus and can lead to stricturing. With kids and teens, you always worry about corrosive ingestions such as lye, medications for acne such as tetracycline, and lastly, Crohn's disease. Here's some spectrum esophageal strictures. You can see here's 3 different cases of chronic reflux. The one on the left is a peptic stricture. Here, the one in the middle is cancer with highlighted with the arrow in Barrett's metaplasia, and lastly, focal stricturing from esophageal cancer. Moving down the esophagus, you get down to another diverticulum. This one's the epiphrenic diverticulum. This is due to dysmotility and pulsion. It's the classic pulsion diverticulum seen just superior to the GE junction. The traction diverticulums are usually seen within the mid or lower esophagus. It's related to mediastinitis or infections like TB. Patients can present with dysphagia. They treat them with, especially the pulsion diverticulums, they treat them when they resect it, and they treat it with myotomy for the motility issue. Now moving on to the dilated esophaguses, we'll start off with achalasia. This is due to spastic narrowing of the GE junction. They got a classic appearance in the chest radiograph where we see a massively dilated tubular air structure in the mediastinum. They can present with an absent gastric bubble. On the esophagram, you'll see this dilated esophagus coming down to a focal narrowing from the spastic GE junction. People describe it as a bird's beak. Other people like to call it rat's tail, whatever you like to use. And you can see disordered motility. This is better seen in this case, where you can see the multiple little contractions throughout the esophagus. That's results from the esophagus trying to get through this spastic narrowing. It's trying to squeeze past this narrowing, get the food down. They're classically seen. Key point is the younger patients. They're usually not seen so you can see these in 20-year-olds. You can see them. I've seen them down to 18-year-olds. So it's not unsurprising to see these in young patients. Here's the classic appearance of the absence of the gastric air bubble, so no air in the stomach. Things to consider. What used to be done is colonic interposition. This was used to be done for a distal esophagectomy. They'd take the colon and pull it up through the chest, but you can see here it doesn't look the same. Another example of a dilated esophagus you see is in scleroderma. This is a patchless dilated esophagus with a patchless GE junction, so wide open GE junction. See it better here on the double contrast, wide open GE junction. What happens is when you lay them flat to go do your swimming views, to take a look for reflux, all that fluid in the stomach is going to freely flow right back up. So you're going to see free reflux between it. So the contrast will actually flow right between the two. So there's no real stop, no real hold up at the GE junction. Another distinction between that and achalasia is it's partially dynamic. You get this atonic patchless esophagus within scleroderma. Within achalasia, you see the spastic paralysis of the esophagus trying to get past that tightened GE junction. Let's look at all 3 of them together. So first, again, narrow GE junction. You can tonic spastic distal esophagus, achalasia. Patchless esophagus, wide open GE junction, scleroderma, and then lastly, the colonic interposition. Esophagitis is commonly seen. You see a ragged, irregular, nodular fold thickening. It's commonly seen within reflux or prior corrosive ingestion, or with immunocompromised patients. You can see it with candidiasis or herpes. In cases of candidiasis or HIV esophagitis, you can sometimes see these large, discrete ulcers. Moving on to food bolus impaction. These patients present with acute symptoms of something getting stuck in their chest. It's usually after a large meal. They're not chewing their food completely. They just the reason sometimes they'll come to us is the fizzies that we give them for their upper GI examination actually helps the food get through. So sometimes it's actually a curative measure too. In one interesting study of 17 patients presenting with food impaction bolus, the most common causes were reflux and dysmotility, but none of them had cancer. So it's usually, if you see this, it's usually just you have to think of reflux or dysmotility, but not cancer. Diffuse esophageal spasm, what it is it's a motility disorder. You see these spastic contractions. Sometimes people call it the corkscrew or nutcracker appearance. Patients sometimes present with symptoms of dysphagia or regurgitation, but also they can present with this excruciating chest pain that mimics acute coronary syndrome. So they come in with these chest pains, they're describing the left chest, and they're trying to figure out, is this a MI? They get worked up. But the thing is, the things that you can treat esophageal spasm, you can treat for myocardial infarction or heart attacks. Calcium channel blockers and nitrates, they both will cure this, they both will help relieve esophageal spasm. So when you give them that, the pain goes away. It's sometimes hard to tell the difference. Myometry is gold standard, that's how you diagnose it. So we moved through the esophagus and now down to the stomach. Whenever you see this, looking at the stomach, you always worry about gastric cancer. It's the second most fatal cancer worldwide. Why do I put this number in here? Well, in a blinded study of 100 patients, we can clearly see endoscopy trumps upper GI. So why do we still do it? Well, a lot of times we do it as a stage. Endoscopy is more invasive. It takes longer to get scheduled. So sometimes what we'll do is we'll do the upper GI examination, look for a large mass or a definite filling defect, help the endoscopist, or if we see a large mass, then they can go right to CT for staging. But if you don't, that doesn't mean that there's not something there. Here's some more examples of gastric cancers. You can see diffuse loss of pliability, non-distension, and a classic linitis plastica from infiltrating adenocarcinoma. A different patient coming in with fatigue and weight loss. You can see a polypoid mass on this double con in the distal stomach. So what is linitis plastica? It's a term meaning leather bottle stomach. What it is, like I said, it's all about dynamic exam. You have to see whether the stomach or the esophagus, small bowel, or anything distends normally. So what it is there's diffuse narrowing, loss of pliability. You can see that the distal stomach and gastric fundus are both wider than the gastric body. The gastric body should distend very well on a double con upper GI. This is a patient with gastric cancer. You can see it also with metastatic breast cancer, as is seen in this case. This patient's got PET CT with diffuse FDG avid wall thickening, and on top of that, you can see the FDG avid liver metastasis. Other things to consider: corrosive ingestion, lymphoma, and sarcoidosis. So thickened gastric folds, that's defined as greater than 1 centimeter in size. Whenever you see this, you think of inflammation, like gastritis, but other things is infiltrating diseases like tumor, lymphoma. Then there's a disease called Mentrier disease. That's the hyperproteinemic edema. It's a self-limiting process in childhood, but if you see it later in adults, it can actually progress. So you get a lot of loss of electrolytes and electrolytes unbalance. And lastly, gastric fundus varices, which are often seen in the gastric fundus. So filling defects within the stomach, you always worry about any filling defect we see within the GI tract during your upper GIs. You always worry about cancer, malignancies, or metastasis. So the common ones that affect the stomach are lung, breast, melanoma, and renal cell. Other things you can see are multiple polyps. You can see from hyperplastic polyps, or you can see in the polyposis syndromes. You see multiple nodular fold thickening going up into the esophagus. You can also see it with varices. Think of that. Also, this will change depending upon patient's position, so you can change to see whether they also change with distension. Lastly, sort of a rare one, the pancreatic rest. You'll see this along the inferior antrum. It's a single round filling defect with this umbilic right here. Here's the example, upper GI, and here's the endoscopic correlate. So moving down into the duodenum. So the first thing you always worry about whenever you're looking at a duodenum is you have to worry about duodenal ulcers. On barium, like you see in the stomach, they're round pools of barium surrounded by a mound, edematous mound. You got radiating folds going to and from it. When they're healing or when they've healed or in the process of healing, they get sometimes spastic narrowing, so you get this focal narrowing of contractions around it. Whenever you got a duodenal ulcer, you always have to worry about perforation. So how do we look for pneumoperitoneum? Again, it's always the classic free air to the diaphragm on an upright chest. Things that you have to think about, though, whenever you see isolated lucency under the right diaphragm, Chilaiditi syndrome. What it is inapposition of the colon between the liver and the right diaphragm. Really, what the only significance of this is that it can mimic free air. That's really the only significance of it. It could totally look like free air. Like this case, this was actually just colon. Here's the normal stomach bubble, but not free air. So that brings up, how do you approach free air? Suspected perforation, you get an upright chest radiograph, normal, supine chest radiograph, and supine x-ray, abdominal x-ray, normal. What do you do next? The left lateral decubitus. This can detect very small volumes of free air, or if you see it, for example, if you looked at that Chilaiditi syndrome and you still weren't sure, get a lateral decubitus radiograph. You can detect very small volumes of free air. Duodenal fold thickening, this is usually associated with some duodenitis. The things that can cause duodenitis, celiac disease, Zollinger-Ellison, pancreatitis. A lot of times you can use the history about the patient to really get what the true cause is. But then if you're looking at it, you find it incidentally, you have to worry about things like varices. So if the patient's got a history of cirrhosis, then it could be varices. The patient has a history of gluten intolerance, well, you got your answer of celiac disease. Moving down to the small bowel, can't really talk about the small bowel without talking about Crohn's disease. The most common aspect of the small bowel to be involved by Crohn's disease is the terminal ileum. It's transmural inflammation. They usually present with these chronic, recurrent, smoldering episodes of abdominal pain, usually localized right lower quadrant because the terminal ileum is the most commonly affected site. They begin with these small, little, tiny ulcers that progress as the inflammation recurs and occurs again to cobblestoning. Again, you see small, little ulcers in cobblestoning. You can see what's called the string sign of contour. It's a long, tight stricture, as you see here. The terminal ileum, non-distendable, didn't change no matter how much we pushed on it, always stayed narrow. Remember, you have to make sure that you're not just seeing a focal narrowing. You have to make sure it doesn't ever change. Lastly, because of transmural inflammation, you can get multiple fistula. They can go anywhere in the tract. This is just an example of a enteroenteric fistula, multiple little enterics. Fistulas outlined by the arrows. So like Crohn's disease, which can involve any part of the GI tract, scleroderma can do the same. People primarily think of it scleroderma involving the esophagus, but you can see it can involve the anal rectum in about 50% of the cases, as well as the small bowel and the colon. For the small bowel series, you see these sacculations or broad-based pseudodiverticulum is highlighted here. Like the esophagus, again, it's atonic. So you get these atonic or dilated bowel loops. You get the hindbound, so the tight folds, all the folds. The hindbound comes from the leathering appearance. That comes from the term from leathering. So it gets these like very tight appearance of the small bowel folds. You can see here, all of them pulled together tightly. So let's look at this case here. This is a 42-year-old man with weight loss. Focused cone-down view of a small bowel series. The striking thing is multiple small, almost like little sand-like filling defects throughout the whole small bowel. This is a classic lymphoid hyperplasia. Clinical associates, it's usually idiopathic, but it can be seen with the hypogammaglobulinemias, lymphoma, giardiasis. So anytime you see these small little filling defects, that's what you should consider. Radiographically, there's small little submucosal nodules. Again, it can involve any part of the GI tract, so you can see it in the esophagus. It's not as common. Usually, the majority of the time, you'll see it within these small bowel. So what's your differential for small bowel filling defects? I usually categorize into three things: inflammation, infiltration, and neoplasm. So inflammation, we talked about nodular lymphoid hyperplasia, but you can see it from Crohn's disease, but those are usually usually larger, more regular. Infiltration, you can think about Whipple's disease, mastocytosis, Waldenstrom's, and lastly, filling defects. Again, you have to worry about lymphoma or polyposis syndrome. Small bowel fold thickening. This is an example right here, nicely demonstrating a patient with a history of rectal cancer. Thick folds, they describe it as like a sawtooth or stack of coins appearance. Your differential is edema, hematoma, Crohn's disease, radiation. Talking a little bit about graft versus host disease. The key history here is allogenic bone marrow transplant. It can affect any part of the GI tract, but primarily you see it within the small bowel. For the small bowel series, you get thickened small bowel loops. The classic things people describe as the sequelae of the graft versus host disease is this ribbon-like or toothpaste small bowel. If you ever take toothpaste and squirt in the water, you'll see it. It's like this featureless loop of a tube. There's other things that can cause this appearance: graft versus host, sprue, ischemia, Crohn's disease. But again, the history will reveal itself. If it's a young patient, it's probably not going to be ischemia. You can think of sprue, graft versus host. Again, it's the history, right? If they've had a history of bone marrow transplant. And lastly, Crohn's disease. You usually look closely if the TI is not involved and the rest of the bowel looks normal, you just see this. It's probably going to end up being one of these two up here. Lastly, for me, I can't really talk about the small bowel without talking about celiac disease. This is something I study closely. What it is, it's also known as the non-tropical sprue. It's a result of gluten intolerance. These patients often don't know they have these symptoms or signs. They come in with these waxing and waning symptoms. They come in from a trip that they had this huge gluten load. They didn't expect. They come in with the abdominal pain. Sometimes they come in with a CT scan that's negative. They get an upper GI examination for further evaluation. And what do we see? We see these diffusely dilated, fluid-filled small bowel loops. You get the classic reversal of folds. The ileum looks like the jejunum looks like ileum, and people like to describe the duodenum looks like hell. What it is, you get this duodenitis, you get this massive inflammation of the duodenum, and that's how they make the diagnosis. That's the diagnostic hallmark. They biopsy it, they make sure they look for signs of celiac disease. Other blood tests that people can do, if they suspect it based upon history, they can just do an anti-glandin antibody test. So lastly, moving down to large bowel. So back in the day, we used to do a lot of double contrast barium enemas looking for polyps for failed colonoscopy. You can see it's not very sensitive for even for large polyps greater than a centimeter. What does that mean? Well, you're missing about 5 to 10, you're missing 50% of these lesions, and in 10 years will turn, 1 in 10 of them will be malignant. So that's why a lot of people are moving now to CT colonography. Here's a nice example of a 5 millimeter polyp seen with endoscopy. And here's the virtual colonoscopy. This has been championed by Dr. Judy Yee from UCSF. And patients tolerate this a lot more than double contrast barium enema. People don't realize when they order the double contrast that this involves gymnastics. People are moving up and down, head up. Double contrast for the CT colon, you just lay on your back, lay on your stomach, you're done. So it's actually much more tolerated than the double contrast barium enema. So moving from the polyp now from precancerous to malignant, the colorectal cancers. On imaging, you can see what's called the apple core lesion. What it is you've got a focal irregular narrowing. As the cancer, it's eating its way along the mucosa, and you got shouldering of the normal mucosa, proximal and distal to it. 70% of the time it occurs within the rectosigmoid colon. It's about 80%, so double contrast barium enema, it's about 85% sensitive. Here's some more examples. Again, here's a polypoid cancer. This is a distal, in the distal rectosigmoid, polypoid mass seen here on the lateral. Here it is on the AP radiograph. A little aside about the volvuluses, so we'll talk first about the cecal volvulus. It represents about about 1 to 3 adults bowel obstruction. Interesting fact is they usually are seen as younger patients, so about 20 to 40-year-olds, so not the typical older patient that we think of when you think of volvulus. It's a surgical emergency. It's a closed-loop obstruction. There's twisting on its pedicle. It's necrosing it's cutting off its vascular supply. On abdominal radiograph, you get this diffusely dilated bean-shaped loop of bowel. It could be the left upper quadrant, right upper quadrant, depending whether it twists or flips. You can sometimes see 1 or 2 focal hostia margins, and you don't have to see. So if it's a very acute sign, they come in very acutely, you can still have air within the left colon, and you can have decompressed small bowel. So primarily you're looking for that dilated loop. If in doubt, sometimes they still will do these. They'll get a water contrast, barium enema, to show that you got no filling of the cecum or ascending colon. The sigmoid volvulus is a result. It's usually seen in the elderly patients, recurrent laxative use. They come in with acute and chronic symptoms. This is the classic inverted U. Follow it down into left lower quadrant. Follow that fold. It'll point you to the origin. It's seen usually, the descending colon is seen behind it, so you can see right here, here's the descending colon going posterior to it. Usually it's treated with the non-strangulated or non-acute patients, tube deflation, elective resection. But as you can see, without the elective resection, almost 50 to 90% of them recur. If they've got strangulated signs of ischemic bowel, then they go to emergent resection. Going a little bit about ischemic bowel and ischemic pneumatosis, pain disproportionate to exam. Biochemical signs of lactic acidosis and also leukocytosis, risk factors. Again, anything that can throw a clot or hypercoagulable states, so atrial fibrillation. This is a bad sign, right? 50 to 90% of them will die, mortality rate. Early diagnosis may help. So again, this is where you get the small linear filling lucencies within the bowel wall. Sometimes you can see portal venous gas if it's really progressed. Like this patient who had a closed loop obstruction, these little branching lucencies in the right upper quadrant. Lastly, can't really talk much about the large bowel without speaking about ulcerative colitis. It's mucosal inflammation, ulceration. You get these small little column button ulcers as the inflammation goes within the wall. It always extends from the rectum proximally. And you can see this like granular or undermined mucosa. You get these pseudopolyps or filiform polyps. Lastly, if the patient's got chronic ulcerative colitis, you always have to worry about cancer. Some take-home points before we move on to the questions. Pattern recognition. It's all about pattern recognition. Don't miss perforation, volvulus, portal venous air, pneumatosis, or lastly, if you're looking at a postoperative film, always worry about the retained sponge. With a fluoroscopy, always worry about cancer. Always have that in the back of your mind. If you're not sure, if you see something you're not sure about, endoscopy is always the safe.